care plays in providing timely, high-quality care to our nation's veterans. I represent a rural state, and during my time as a member of the House of Representatives, I represented a congressional district approximately the size of the state of Illinois. There was no and is no VA hospital included in that geographic territory, and so I bring this perspective of long distance and long amounts of time for veterans to access care. I've heard countless stories from veterans in Kansas and across the country who live in faraway places from the VA facilities about those challenges. In the absence of VA's community care program, these veterans would not be able to use the VA health care benefits they earned. The same can be said for veterans who face long wait times at the VA, veterans who require a service that the local VA doesn't offer, or veterans who have unique needs that are best served through community care. The Mission Act was created so that the VA could more seamlessly care for those veterans. However, 7 years after the Missions Act was signed into law, it is still not fully living up to its promise. I have heard from veterans nationwide who've suffered as a result, especially over the last year, as VA acted to discourage and restrict the use of community care under the Mission Act. Some of those veterans who've suffered the most are those with mental health conditions and addiction. This morning, we will hear from veterans' family members. We'll hear from veterans and advocates about how they encountered barriers at the VA which limited veterans' access to potentially life-saving care and put their lives at risk. One of those veterans is Eric Golnick, who will testify today about waiting more than a year to be connected to a counselor after asking the VA for help in the midst of a personal crisis. Another one of those veterans is Paige Marge's husband, Charlie. Paige will testify today about how her and Charlie repeated requests for inpatient care were denied by the VA after Charlie attempted suicide in the parking lot of a VA clinic. VA leaders and advocates have repeatedly said that suicide prevention is one of their top VA's priorities. If that is indeed true, stories like the ones Eric and Paige will share, and the countless others that this committee has heard from, veterans and their loved ones, should not be happening and cannot be allowed to continue. As chair of this committee, I'm committed to making certain that they do not. That is why I'm introducing legislation today with Chairman Bost, my counterpart in the House, to strengthen the Mission Act and give veterans like Eric and Charlie an improved pathway to care in the VA's direct care system and in the community. And I hope this will be a bipartisan effort. The VA healthcare system is an invaluable resource for veterans, but it will only remain so if it stops failing those who need it the most. With that, I yield to the ranking member, Senator Blumenthal, for his opening remarks.
Thank you, Mr. Chairman. This cause must be bipartisan and it must be immediate. There is no question about the need to speed, streamline, and safeguard access to community care and referrals to the kind of providers that are necessary to prevent the tragedies or near tragedies such as your husband, Charlie, suffered, Ms. Marge. I believe strongly that these two systems, private and VA, must be complementary, not competitive. And overriding all of this debate is the need for more providers, more doctors, more nurses, more psychiatrists, and social workers who can provide the kind of care that our veterans need. And obviously, the VA should not be in competition with communities for the numbers of scarce providers, skilled professionals who are necessary to provide this care. But we're here on a morning when all of these programs are in severe and urgent jeopardy. The Trump administration has announced illegally that it will freeze federal aid for programs that are immensely important to veterans. This freeze on federal aid will hurt veterans by pausing funding for critical programs that millions of veterans and their families rely on. We're talking about homeless veterans, funding for veterans' nursing homes across the country, suicide prevention programs, many of the programs that we will be discussing today and the efforts to streamline, speed, and safeguard access to community programs, reimbursement for those providers who need it to make community care work, frozen. We are deterring and discouraging that kind of community care right now in real time. And I urge all the members of the committee, I urge my colleagues to oppose this measure, to make their views known. I call on veterans and their organizations across the country to make their views known, because these funds must be freed immediately or else veterans will be betrayed. There's nothing woke or Marxist about working to end veteran suicide or delivering our veterans the benefits they've earned and deserve. And I will put in the record later today a list of programs. It's going to be probably about 2 pages long. I have a tentative list here that will be adversely impacted by this freeze on funding. It is also, by the way, unsustainable legally. It violates the Impoundment Act. These funds have been lawfully appropriated under bills passed by the Congress and signed by the President, and no member of the executive branch, including the President, has the lawful power to simply stop them. I am concerned also about the action to dismiss the Inspector General. I'm going to be circulating a letter to my colleagues that would, in fact, protest to the President the firing of the VA's Inspector General, Mike Missel, who has worked for many years under both Republican and Democratic administrations to call out and stop waste, fraud, and abuse. He's done it in a very bipartisan, or actually non-political way, aggressively and effectively. And the question for all of us is why this measure of firing the Inspector General of the VA was done at this moment, when in fact he has been the bulwark against waste, fraud, and abuse in the VA, as have Inspector General across the executive branch. I believe strongly that the private sector healthcare system and the VA are complementary, and one route to care should never come at the expense of the other. I fear that's what's happening today. The erosion of VA direct care is a real threat, and I say erosion because it could happen gradually, not all of a sudden, but if it happens, it may well be irreparable. I am hopeful that we will restore the Inspector General, that we will make sure that the funding for the VA system and other programs will be unfrozen, and that we will work together in a bipartisan way to speed and assure the referral system under the kind of legislation that the chairman has proposed. There was an effort last session, and I supported it, to legislate in this area. I'm hopeful that his measure is one that we can all support. I know last session he offered the Veterans Health Act. I assume that this measure is similar to it. Ranking Member Tester offered the Making Communities Care Work for Veterans Act. I feel some combination of these measures is viable and achievable, and I'm hopeful that we can reach a bipartisan effort. Thank you, Mr. Chairman.
Thank you, Senator Blumenthal. I would indicate just a couple of things for all of our members. It's my understanding that the Department of Veterans Affairs leadership is meeting later this morning with OMB to learn details of this issue of impounding or withholding funding. And I would say that in both instances, both the Inspector General and this issue, one of the best things that we can do is get Congressman Collins confirmed and in a position to represent the Department of Veterans Affairs in these matters, and that is apparently taking place this week. I'll now call on our witness panel. Let me introduce them. Eric Golnick, a Navy veteran and an advocate for mental health and suicide prevention for veterans and first responders. Paige Marge, a veteran spouse with firsthand experience in navigating the VA healthcare system on behalf of her Air Force veteran husband, Charlie. Jim Lorraine, the President and Chief Executive Officer of America's Warrior Partnership. Naomi Mathis, the Assistant National Legislative Director for Disabled American Veterans, and John Eaton, the Vice President for Complex Care for the Wounded Warrior Project. Thank you all for being here this morning. More importantly, thank you for all you do in care of veterans and your care and concern for your loved ones. Mr. Golnick, we'll recognize you first, and you are recognized for 5 minutes.
Chairman Moran, Ranking Member Blumenthal, and distinguished members of the Senate Veteran Affairs Committee. Thank you for the opportunity today to testify on the critical issues of improving access to care through the VA's Community Care Program. My name is Eric Golnick. I'm a U.S. Navy veteran, and I've dedicated my life to supporting the health and well-being of veterans and first responders. The VA is an essential resource for millions of veterans. Community care under the Mission Act is meant to complement, not replace, the VA services, ensuring veterans receive the right care at the right time. I'm going to begin by sharing a personal story to show you why this is so important to me. After leaving the military, I sought mental health care through the VA. I was fortunate to see a psychiatrist relatively quickly, but it took over a year to see a therapist. The lack of therapy meant I was only addressing part of the problem. This came to a head over the holidays a few years ago, and without the support of friends and fellow veterans, some of who are in this room, I may not be here today. For someone with a mental health or substance use disorder, the window to intervene is often just days. For veterans, timely access to this care is a matter of life and death. My experience reflects the systemic barriers many veterans face in accessing timely care. That's what inspired me to co-found Forge Health in 2016. We addressed urgent mental health and substance use needs for veterans and first responders, working closely with the VA to help those who couldn't find adequate care. The collaboration showcased the potential of how these relationships could work with the community, but it also highlighted the potential challenges. Some VA MCs and VISNs fostered strong partnerships. However, inconsistent implementation across the system resulted in delays, highlighting need for clear, standardized practices to ensure veterans receive timely and consistent care. While the Mission Act has expanded options for veterans, many don't know about these options. Unclear eligibility requirements often lead to delays or denial, even for those who meet the access standards. One veteran, after being told he couldn't continue care that he developed a therapeutic relationship with a clinician for over a year, told me, "I'm done. I give up." Before this year, I had been through 4 clinicians in less than 6 months. When transitioning from VA to community care, many veterans face disruptions caused by poor communication and unclear processes. For example, a Marine veteran I worked with struggling with severe post-traumatic stress was referred to community care, but waited months due to administrative delays. During that time, his condition worsened, and he attempted suicide with a firearm. Some VA employees hesitate to refer veterans to community care, fearing it could negatively impact their budgets. This can create barriers, forcing veterans to choose between systemic concerns and urgent care needs. The Mission Act was designed to ensure timely, high-quality care, whether through the VA or through community providers. Veterans and not funding structures should remain the top priority in the care of veterans. To address these challenges, the VA should enhance its efforts to educate veterans about their options under the Mission Act. Clear communications during VA appointments, proactive outreach campaigns, and partnerships with VSOs can ensure veterans are fully informed about their rights and choices. The referral and approval process should be streamlined. Simplifying and automating these procedures can reduce delays, alleviating administrative burdens, and help veterans access care more efficiently. This includes ensuring that community providers, TPAs, and VISNs are all in transparent and constant communication. For rural and underserved areas, community care should act as a force multiplier and not a replacement for VA services. helping the VA fill and address critical service gaps. Telehealth is also a powerful tool for bridging these service gaps in these rural and underserved areas by providing immediate access to care. However, challenges such as limited broadband access could make this option unworkable. It's also crucial for some veterans, especially when you're talking about mental health, to have the option to see an in-person provider, especially if you're processing trauma. Chairman Moran, Ranking Member Blumenthal, and members of the committee, the VA has made progress in improving care for veterans, but significant challenges remain. By addressing these barriers and building on the foundation of the Mission Act, we can ensure that all veterans receive timely, high-quality care they deserve. It's our responsibility to ensure no veteran is left behind. By fostering collaboration and prioritizing veterans' needs, we can fulfill our promise to those who served. Every delay risks a veteran's well-being and their life. As one veteran told me, I shouldn't have to fight this hard to get help. Thank you again for the opportunity to testify. I look forward to your questions and working together to improve the care for our nation's veterans.
Mr. Golnick, thank you for your testimony and for your service. Ms. Marge.
Good morning, Chairman Moran, Ranking Member Blumenthal, and the members of the committee. Thank you for the invitation to speak at today's hearing. My name is Paige Marge, and I am the wife of Charles Marge. I'm not here to talk about the life of my husband in the past tense.
It is, but... Yeah, sorry. You got it.
Better? My name is Paige Marge, and I am the wife of Charles Marge. I'm not here to talk about the life of my husband in the past tense, but I'm here to tell you how Charlie was saved. Countless times the VA and community care program could have provided impactful mental health counseling, resources, and residential treatment, but failed again and again. I met my husband 27 years ago. We've been married for 23 years. In this time, I have seen my husband change dramatically from a pivotal deployment that he went on. In October of 2012, Charlie deployed from Germany to Guantanamo Bay, Cuba for 8 months. To this day, I'm not sure what happened on that deployment, but whatever did happen permanently and profoundly changed my husband. In August 2013, while still on active duty, Charlie attempted suicide and was hospitalized at Landstuhl Regional Medical Center. It was then that he disclosed that he attempted suicide twice on deployment. His doctors told us that he could not have PTSD because he was not deployed to a combat zone. He was diagnosed with major depressive disorder and anxiety and was medically retired in July of 2015. We moved back to San Antonio and Charlie enrolled in the VA Heart of Texas Healthcare Network. He was connected to a VA psychiatrist who only supported his mental health journey through medication. Counseling is not part of these quarterly appointments. Charlie has repeatedly requested counseling referrals from the VA psychiatrist, and the cycle that includes the community care program failed Charlie again and again. He would wait 6 to 8 weeks for the referral to be processed to see a community care provider. In each of the 9 times that he went through this process, he's never been granted more than 12 visits with a counselor, even when he needed them more. And in each cycle, he saw a different provider, and he spent time retelling his story and building rapport. In February 2023, Charlie went to see his VA psychiatrist to request immediate mental health support as he was in crisis. We were told to go outside of the VA to seek care, and we were given a list of local providers who accepted TRICARE. The earliest appointment that we could find was 30 days out. On March 1st, 2023, my husband sat in his truck in the VA clinic parking lot and attempted to overdose on his medication. I found him in his truck, drenched in sweat, crying and incoherent. He was transported to a local hospital. When he was released, he was referred again to the VA community care system for counseling and was seen for 12 visits before he was released from care again. His medication was adjusted multiple times over the next 6 months. Towards the end of this period, Charlie went missing and was found by the police in the ER waiting room at Audie Murphy VA Hospital. He was held on an emergency detention order and admitted to the psychiatric ward for 36 hours. For several reasons, I asked if he could be sent to a residential program and was told that no option like that existed through the VA. At his follow-up appointment, I explained the last few years of navigating fragmented community care counseling and that these 12-session appointments were not adequate support, and that a longer-term solution was needed for him. I again requested that he needed to be put in a residential treatment program. A referral was submitted for residential treatment to the community care program. Charlie's psychiatrist called and told him that the referral was denied and suggested that he reach out to TRICARE, Wounded Warrior Project, or another veteran service organization to get the care covered. Wounded Warrior Project's Complex Care Coordination Program assigned a case manager, and within 3 days, paid for his flight to Tucson, Arizona, secured a bed for him at Sierra Tucson, and paid for 6 weeks of residential inpatient treatment. Sierra Tucson is in the VA's community care network, and the VA should have covered this expense, but failed to support Charlie again. While he was there, all of his medications were changed and reset. He received intensive counseling, treatment for his nightmares, and was diagnosed with PTSD. Since he returned home, Charlie has avoided the VA for mental health support because he did not want to go through the familiar cycle of fragmented care again. Instead, he has sought outside support through local nonprofits. Charlie is currently attending counseling appointments through the local vet center in San Antonio. Wounded Warrior Project saved his life by getting him connected to care that he desperately needed for years, that over and over again the VA fell short on. It's heartbreaking to see your spouse become a shell of a person, to repeatedly ask for help, to maintain prescription compliancy for more than a decade, and to not miss appointments, only to be discarded from the entity that should be providing treatment and care that he earned through his military service and sacrifice. The obtuse, heartless interactions with the VA over and over are why veterans do not seek care. It's why veterans suffer in silence. How many veterans need to commit suicide for the VA to prioritize long-term mental health care? How long do veterans have to wait for mental health care? How many veterans are getting lost and giving up in the community care system that do not have someone to advocate and fight for them? We need the VA to be better. Thank you for the opportunity to share Charlie's story.
Ms. Marge, thank you for your must be difficult testimony, but very compelling and valuable to me and the members of this committee. Mr. Lorraine.
Chairman Moran, Ranking Member Blumenthal, and members of the committee, I'm honored to testify today regarding veteran access to health care, specifically care in the community. The ability to make our own decisions is a foundational American freedom. I've always told my Army-serving son that a successful career should give him the choices throughout life. I remained in the military through retirement because I love service. But I also did it to ensure I had choices, especially managing my health care through TRICARE or the VA, something my father, a World War II veteran, never had the option. AWP believes veterans have a choice in managing health care they've earned. Providing veterans with health care choices of where, when, and most importantly, the continuity of care they seek is not only the right thing to do, but it's also affordable and effective. AWP operates at a community level. By building proactive relationships with veterans, our mission is to partner with communities to holistically improve the quality of life of their veterans and their families, thereby reducing veteran suicide. Community care is a vital tool for veterans, particularly those who don't trust the VA and who don't utilize the VA facilities due to the factors like distance, time, and continuity. While we recognize the VA's crucial role in veteran care, AWP always sides with the veteran. We have supported empowering veterans to make their own health care decisions, and community care is one of the most popular and in-demand options. The Mission Act and community care enabled veterans the opportunity to access outside VA facilities as a result of has been overwhelming. Community care helps veterans regain the trust in the system, especially given that almost half of the 17.6 million veterans in the United States are unknown to the VA. At AWP, nearly 9,000 veterans contacted us in 2024, over 4,000 needing assistance, most often related to health care. These 4,000 plus represented 6,000 issues. 392 related to mental health. Of those 392, 329 had suicidal ideations within 30 days of contacting us. The most common theme we see is a struggle to access care. Even for veterans familiar with the system, navigating the VA can be frustrating. Confusion, long wait times, and canceled appointments erode trust in the system. Though it's popular, full implementation of the Mission Act has yet to be realized. In the past years, the VA has continued to deny community care referrals, continue to expand VA hospitals, continue to hire more employees, often competing with the private providers for talented medical professionals in the community. We must get this right. Mr. Chairman, as you said during Mr. Collins' confirmation, America's national security is dependent on an all-volunteer military force. And the VA that is successful in helping service members thrive as veterans is key to bolstering recruitment and keeping the nation safe. We agree 100%. And feel that the VA is not a social service department, it's a national security entity. Despite some opposition and clear data, and data is clear, veterans are voting with their feet to seek outside care outside the VA. The department should trust and empower veterans by allowing them to choose their care providers. After all, who knows what's best for the veteran, the government or the veteran? In my experience, both my wife, who's a veteran, service-connected disabled veteran, and I have faced challenges accessing care in the VA. After years of frustration, we seek our care through TRICARE and Medicare, because it provides us with so many other choices. Community care is essential. Veterans should be able to choose their providers who meets their needs the best. AWP has put forward several recommendations for improving care. Codifying the access standards. Congress should codify the existing access standards for the community to ensure the veterans have guaranteed access to timely health care. Eliminate the referrals for veteran health, substance abuse, and TBI care. I add TBI care because it's essential. We need these services is often urgent, as Ms. Marge said, and referrals delay needed help. Further TBI assessment and care have been neglected because of their similarities to post-traumatic stress disorder symptoms. We must include TBI services when discussing mental health and substance abuse. We also feel that we need to educate veterans on community care options and allow veterans the preference for community care, and allow veterans to utilize TRICARE Select. Community care is essential to improving veterans' access to health care. We must continue to improve the system by empowering veterans, not restricting them. Together, we can do better. Thank you, sir.
Thank you, sir. Ms. Mathis, welcome.
Thank you. Chairman Moran, Ranking Member Blumenthal, and members of the committee. Over the past decade, due to increased demand for services, VA's reliance on purchased medical care services has risen significantly. While the use of community care has grown, many veterans have encountered barriers to accessing that care. DAV supported the VA Mission Act, which aimed to improve veterans' access to timely, high-quality, and veteran-focused care. Importantly, this support was based on maintaining a fundamental set of principles. Unfortunately, there are reports from some veterans indicating that they have been denied eligibility and access to the Veteran Community Care Program. The access standards enacted in the Mission Act are clear, and VA is responsible for educating its employees on the law and veterans' rights to access community care when VA cannot provide needed care in a timely manner or due to distance from a VA facility, in cases where it is determined to be in the best medical interest of the veteran. We also continue to hear about delays in scheduling community care appointments once a referral has been made. Due to the lack of an interoperable health record system, VA struggles with transmitting patient records to community providers and integrating those records into the patient's VHA electronic health record. Additionally, community providers report complications with transmitting healthcare information and test results back to VA. There are also complaints from veterans regarding billing issues associated with referrals to community care. VA must find an effective solution to ensure that patient records are transferred in a timely manner and provide community care providers the tools and procedures for transferring records back to VHA. VA should also require the return of patient records to VHA before payments for services rendered are made. Finally, VHA must ensure veterans are not erroneously billed and burdened with resolving billing issues related to community referrals. A bipartisan issue and VA's top clinical priority is suicide prevention. Yet it does not mandate community care providers to meet the same training and quality standards as VA direct care providers. DAV recommends VA amend its contracts with these providers and require clinicians who treat veterans to be trained in military culture, suicide prevention, lethal means safety counseling, and trauma-informed care. Accessing mental health and substance use disorder care is essential in preventing veteran suicide, and we made recommendations in our testimony to ensure quality services are provided to veterans referred to the community. Women veterans are also significant users of community care. They are referred to the community for all maternity care and oftentimes for other basic gender-specific or specialty reproductive health services. Although we want to see fixes to improve access to services in the community, we strongly believe that investing in VA's comprehensive, veteran-focused, evidence-based care model is likely to produce better health outcomes for veteran patients and ensure quality of care. It is essential to maintain VA as the primary provider and coordinator of veterans' health care. A bipartisan position supported by current and past VA secretaries and undersecretaries of health. A robust VA healthcare system also provides vital research, essential clinical provider training, and emergency preparedness for veterans and the nation. The failure to adequately fund, maintain, and expand VA's direct care infrastructure and increased staffing levels to meet rising specialty care demand has led to unsustainable growth in community care, threatening the long-term viability of the entire VA healthcare system. Likewise, an improperly managed veteran community care program has resulted in some veterans receiving substandard care. In closing, Congress and VA must work together to resolve existing issues impacting veterans' health care. Improvements need to be made expeditiously to ensure veteran patients receive quality, timely care. Most important is to maintain a veteran-focused health care system for service-disabled veterans who rely exclusively on VHA for their health care needs. Ensuring VA specialized care and services remain available is part of honoring the commitment to those who served. Mr. Chairman, we look forward to working with you and the committee. This concludes my formal statement.
Ms. Mathis, thank you for your testimony, and thank you for DAV's continued presence before members of this committee and the committee when we're meeting. Thank you for your testimony. And Mr. Eaton.
Thank you, Chairman Moran, Ranking Member Blumenthal, and distinguished committee members for this opportunity to speak with you. Since 2003, Wounded Warrior Project has been working to transform the way America's injured post-9/11 veterans are empowered, employed, and engaged in their communities. Over the past 20 years, our programs and services have matured to a point where we can now engage with each individual based on their unique needs. Part of our process for helping warriors is learning more about their journey to Wounded Warrior Project. And some of these veterans have used VA for mental health care, others have not. Using VA is not a prerequisite to accessing our free programs and services, nor is it a requirement to keep engaging with us. But as a majority of warriors we serve use VA, and nearly half report using VA for mental health care, we often learn about what that care has looked like for those who come seeking mental health care and support from us. For some, wait times are still an issue. Despite efforts to expedite access through the VA Mission Act, many warriors have reported wait times of several weeks to months before being provided with a mental health appointment. This is typically when a veteran or their family reaches out to organizations like ours for help. We have a relationship with direct care providers and can help triage veterans into care sooner in many cases. And while the VA has its community care network for a similar purpose, we've learned that some warriors still wait for care well beyond 20 days after being referred to a community provider. For some of these same warriors and others, we hear of frustration with provider turnover at the VA. It can take time to develop the kind of trust and rapport with a counselor that is critical to effective care. But when VA mental health providers leave the VA system, their patients are left to start over. This can be an agonizing process for some, particularly those who struggle to tell their story. And even as some veterans are referred to the community, an enduring relationship with a community-based provider isn't always possible as VA workloads adjust and authorizations for external care lapse after a course of treatment. And while these stories are not common, the challenge that we've seen firsthand is accessing care through VA's mental health residential rehabilitation treatment programs, or RRTPs. VA's mental health RRTPs provide residential, rehabilitative, and clinical care to eligible veterans who have a wide range of symptoms, illness, or rehabilitative care needs. To be clear, the VA provides inpatient acute stabilization for veterans in crisis or suffering from severe mental illness. RRTPs serve as a step down to that acute stabilization and a more intense treatment option for those veterans in need of substance abuse, PTSD care, and dual diagnosis treatment, for example, in a residential setting. RRTPs serve a small but high-need, high-risk population of veterans. Approximately 32,000 veterans received RRTP treatment at the VA or in the community in 2023. By contrast, nearly 2 million veterans received individual or group mental health treatment in a VA over that same period. And despite the logical association between RRTP and mental health care, the access standards contemplated by the VA Mission Act and memorialized in the Code of Federal Regulations do not in practice extend to mental health or substance use disorder care provided in a residential setting. This becomes a problem even more pronounced when we're working directly with high-risk warriors for placement at the VA or in the community. Stated most simply, we've encountered VA providers who have stopped making referrals to RRTP care in the community even when there's no firm idea of when that care will be available in the VA direct care system. And when this happens, we will pay for that faster connection to community-based, military competent care paid by donor dollars, and with almost no opportunity to secure any reimbursement from the VA. We're proud to step in at this point, but we know we only see a small percentage of the veterans who are seeking this critical level of care. In totality, many veterans are not accessing care they need when they're ready to receive it. Delays in finding appropriate care in a timely manner not only fail to capitalize on the veteran's desire to change their life circumstances, but in some cases cause further damage to their mental and physical health, declines in their family and social relationships, and even involvement with the justice system. To mitigate the risk associated with unpredictable RRTP access and ensure consistent VA help throughout the enterprise, we believe the Mission Act access standards must apply to the delivery of residential programs. We want and need the VA to be successful in this. Simply put, the VA is our most critical partner in connecting veterans to the residential rehabilitative care that they need. In closing, we thank the committee and its distinguished members for this opportunity to share our perspective on VA community care. We're eager to support your efforts and to keep our promise to our nation's veterans, and I look forward to your questions.
In so many instances as you do. Ms. Marge, I want to highlight really the testimony maybe between you and Mr. Eaton. You indicated that on numerous occasions the care that your husband needed was denied by the VA, and the suggestion was that you seek care through TRICARE or through a private organization.
That's correct.
Not-for-profit.
That's correct.
Is that, and that's despite the fact that Charlie had a 70% service-connected disability from the VA.
Correct. And he, his rating has actually increased, so he's 70%, but he is rated as IU for individual unemployability, so he is actually at 100% right now.
And what was the reason that the VA made that recommendation that you seek care elsewhere? How did they explain that?
At his follow-up visit after the second suicide attempt, the nurse practitioner told us that the VA did not do long-term mental health well. And she turned around her computer screen and pulled up psychologytoday.com and told us to search and filter for which providers take TRICARE and to connect to a provider like that. The only explanation was they just don't do long-term mental health well.
Is it true, Mr. Eaton, that the VA could refer Charlie to the same place that TRICARE would be paying for?
Yes, sir.
Under community care, under the Mission Act?
Yes, sir. The location that Ms. Marge highlighted is a member of the Community Care Network and would be eligible for referral.
And that caught my attention that where you have helped find a place for Ms. Marge's husband, Charlie, is also would be eligible for the VA to refer to in community care.
Yes, sir.
How do you explain that?
Well, I think without clear defined access standards, the VA is left to other alternatives to find that level of care. It goes back to education, but also really clear. Whenever a veteran is met with ambiguity in this critical time, you can imagine the different barriers they have to face in accessing care. And so we need clear standards that are dispersed across the entire VA that outline what veterans' options are and what their rights are in this case.
Can I add something to his statement?
Please.
So when my husband went to Sierra Tucson, they actually have a program just for veterans. It's a red, white, and blue program. My husband was there with other veterans and was housed with veterans. Other veterans there had the VA paid for their care there. And so it really seems very hit or miss as to what the provider understands and knows what the process is as to what kind of care they actually get connected with.
That is a partial answer to my follow-up question with you again, is you know of other veteran families that have experienced similar circumstances, or are you just a one-case circumstance?
No, sir. There's other veteran families.
Mr. Golnick, you were nodding your head.
Yes, Senator. We saw this a lot in Forge, where, what's the old saying, you've seen one VA, you've seen one VA. Unfortunately, like I had mentioned in my testimony, some VISNs and VAMCs had a great education on community care, others didn't. And when that ambiguity came in with others, that's where people started, unfortunately, what happened with your husband, you're getting into those things, and it's not necessarily something that is standardized across the system. So that really is the bigger issue.
My impression, and you can correct me if I'm wrong, that often the treatment at the VA, if you remain there for the kind of treatment you need for the circumstances that Charlie and Mr. Golnick both needed, is often opioid prescription. Is that true?
Senator, it's in some cases, right? In some cases it is. A lot of it can be severely and persistent mental illness that the VA works a lot, SPMI. But yes, that is a lot of the times the case.
I don't know whether I made my question clear, at least for the point I wanted to make is there are programs that don't involve opioid treatment, but the VA's tendency is to utilize opioids as a treatment. Is that true?
In a lot of cases, sir, yes, they're looking for a...
Maybe you already answered my question,
Yep,
but I
yes,
wasn't sure. Okay.
Yes, Senator.
Anybody want to add anything to what I asked? And if not, we'll go on to the ranking member. Mr.
Sir,
Lorraine?
thank you, sir. I think the other point that's being missed is that the ability to do case coordination at a national level to understand where the resources are. WWP has figured it out, and they've got a great group of people that do complex case coordination. We work closely with them, but I think that's the absence. There is care out there. It's just a matter of if you know about it, you know about it, but you have to know somebody to know about it. And you need somebody who can navigate the system that way.
Thank you.
And sometimes it's outside.
Senator Blumenthal.
Thanks, Mr. Chairman. What I hear is a common theme. Veterans should have choices. Care should be timely, and it should be high quality. The most skilled professionals in the world ought to be available right away, especially in cases of mental health crisis, such as you experienced and your husband, Ms. Marge. And the best laws in the world demand accountability. The VA must be held accountable. And one of the best means of holding it accountable is an effective Inspector General. Would you agree, Mr. Eaton?
Yes, sir.
Firing an Inspector General sends a message on accountability, and it should be accountability not only for the VA, but also for dollars spent on community care. Would you agree with that, Mr. Eaton?
I believe so, yes, sir.
And right now, the Inspector General is barred from that kind of accountability when dollars are spent in community care. And they're scarce dollars. We can't afford to waste them. Whatever we think about the VA, at least there are means of tracking and record-keeping there that often is unavailable when dollars are spent on community care. We spend a lot of time talking about VA facilities, wait times, for example. That data is transparent. It can be recorded, tracked, and acted upon, but that's not true in the private sector. Mr. Eaton, would you agree that there needs to be accountability in both the private sector and the VA?
I think when you consider access standards, what we've heard from veterans is even if they receive a community care network referral, they could be waiting perhaps longer than they would within the VA system, that 20-day mark. And so I think there's certainly opportunity to identify how we can ensure streamlined care throughout VA's entire integrated system, which includes the community care network.
That point is absolutely critical, that the wait times for community care actually may be longer in some instances, and we need to guarantee, again, the two systems have to be complementary, not competitive, that veterans are not delayed in the care they receive, because care delayed can be care denied, as Charlie's example shows so dramatically and graphically. And I want to thank you, by the way, Paige, for being here today. I know it's not an easy task to be here, and thank you for telling us, being the voice of Charlie's story. I want to talk about the hiring freeze. The hiring freeze was going to apparently deny positions being filled in VA facilities across the country. Doctors, nurses, attendants, technicians, the people who provide direct care. The administration may have walked back that hiring freeze insofar as VA facilities are concerned. We are still unsure, and clearly the hiring freeze still applies to essential core functions the VA provides. And I'm going to ask you again, Mr. Eaton, because your organization was so instrumental in providing care for Charlie, and your organization and Ms. Mathis provides services for veterans, thousands of them, across the country. Isn't this hiring freeze having a detrimental effect on the VA?
Thank you, Senator, for the question. As our team's analyzing the details of the freeze, looking at the exemptions, we note that critical roles like psychologist, social worker, marriage, family therapist, and licensed mental health counselors as of now are listed as exemptions. And so we're going to continue to work closely with warriors to hear their experience throughout the system so that we can step in if and when there's an area for us to support.
But if there are insufficient exemptions, it will have a deleterious effect. I assume you would agree.
Yes, the capacity and timeliness for care is definitely tied to provider capacity.
And the freeze on funding, that affects vital programs, including suicide prevention programs. Just give you one example. Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program provides grants to community-based suicide prevention resources to meet the needs of veterans. You're familiar with it, Mr. Lorraine?
Yes, sir.
Including Easter Seals, for example, in New London, Tolland, and Windham counties in my state of Connecticut. That program now is frozen.
Yes, sir.
In terms of funding. That's a bad decision. Would you agree?
I think it freezes our ability. We connect to 235 veterans a week through the Fox grant. That's 235 veterans I can't connect to.
Thank you. My time has expired. I have quite a few more questions, and I hope the chairman will give us a second round.
Senator Cassidy.
Thank you. Mr. Golnick, maybe 3 years ago, we had testimony that VA was giving people iPads and allowing telemental health and also setting up satellite offices, for example, in a rural area in the back of a Walmart. So it would be as if you're going to the pharmacy, but instead you slip back there, and it would preserve, you weren't going to the psychiatrist with the stigma that might be there, but rather very discreet. I haven't, as I read each of your testimony, I didn't see any reference to that. So I'll throw that open, but I'll start with you. What about this telemental health program? Are you familiar with it?
I am, Senator. Yeah, again, I think there are lots of good options getting out there. And again, I'm not anti-telehealth. I think that veterans should have the opportunity to be able to have the choice between seeing an in-person provider versus a telemedicine care, if that's the only option available.
Well, I only mention that because the rural aspect of it, I mean, this is obviously a way so someone doesn't have to drive an hour to get in and fighting traffic and maybe miss the appointment. I'm a physician. And by the way, Ms. Marge, anybody else have any experience with the telehealth, and is it effective? And because obviously one issue here is the lack of providers. And this was portrayed to us as a way that maybe extra providers across the country would be able to provide services someplace else and therefore give some continuity of care and address that need. Yes, ma'am.
Yes, sir. We agree telehealth is an excellent option. I think, though, when it comes to license portability, there becomes an issue.
Now, for the VA, I'm told...
For VA, it's not an issue.
Not an issue.
Correct.
Right.
But if you're
But
talking
being
about...
specific about the VA right now.
Yes, sir. Telemental health is a very good option, complementary with in-person.
And so is that being fully used and/or is it fully effective? I guess that's because a lot of what we have here is a shortage of providers and therefore requiring long wait times and/or referral. Yes, ma'am.
So my husband has utilized telehealth before in some of his referrals to community care. Personally, for him, he would rather choose to see somebody in person, given the opportunity, especially when he's talking about his mental health struggles.
Next, again, I'm a physician, so when there's so much churn, and that churn has been a feature of the discussions about mental health in the VA for some time, it's telling me something's wrong. Now, it could be that the salaries are less, but then why would you take the job in the first place? Or it could be that the administration is so frustrating that people just don't want to spend the rest of their life in this sort of a situation. Now, you're on the outside looking in, perhaps, but you may have special insights. Any ideas as regards why there is so much churn among providers?
In terms of them getting into the VA, or is...
No, the providers, one of the things I read said they have providers, but there's constant turnover. When you're trying to get that rapport, and then 6 months later you have somebody else, and then 6 months later you have somebody else. And we've seen previous statistics in which there's a lot of hiring, but there's a lot of departures. And so I'm trying to, and there's a pattern there, and it's disruptive of the patient-physician relationship, the provider-patient relationship. Do we have any insight as to what might be causing that churn? Jim?
So, yes, sir. Well, one of the things that we see is not just a churn about leaving the VA, it's a churn about moving within the VA also. I think continuity, and I mentioned it in my testimony, continuity is really critical. And I think when we talk about telehealth, seeing a patient face-to-face as a provider myself, seeing a patient face-to-face can't be replaced by, it can be augmented and enhanced by telemedicine.
I accept that.
But in terms of the churn, it's not, you're moving within an enormous VA system. They just don't, it's not just leaving the system, it's leaving the facility that you're in.
So they may go from Des Moines, Iowa to New Orleans, Louisiana.
Or move within the facility to another area. Yes, sir.
Okay, but then obviously, theoretically, you'd have systems that would limit that.
But you lose your continuity. It's a churn. It's a churn from the individual's level out, it's a churn.
Okay. Okay, well, I thank you all for your testimony.
Senator Diegos.
Thank you, Mr. Chairman. Thank you, everyone, for being here today and for your service to our country, whether by direct service or as a family or a service member. The testimony today illustrates the ways in which bureaucracy is failing our veterans, especially when it comes to veterans seeking mental health care. Personally, I have my personal experience with this. When I first got back from the war, I actually tried to go right to my VA and ask for services for PTSD, was rejected because my paperwork hadn't caught up, and then continued to try to get help, as well as many of my other guys that I serve with, and actually avoided therapy for almost 12 years after that. and luckily am now in and have been. But a lot of us missed some opportunities, I think, to really put ourselves on the right path because of VA bureaucracy back in the day, and this is 2005, 2007 timeframe. So this is, as I say, this is very personal to me, and even now I still talk to my brothers in arms who are now also going through different levels of therapy and or rehabilitation. So thank you for the testimony you guys are providing, because this is obviously important. As well as also, I am disappointed that we didn't get someone from the VA to come and talk, because they could have brought us a very good firsthand experience about really what effective contracting looks like, as well as asking the Government Accountability Office about their assessment of the program last year. And I think that would have given us very good perspective, because we really need to look at this holistically. And for us veterans that use services, get PTSD services or other services, we know the best way to deal with anything of this nature is holistically. So, Mr. Golnick, thank you for sharing your experience seeking mental health care through the VA, and for the work you're doing with Forge Health. Did I say that correctly? Okay, just want to make sure. English is my second language, so sometimes I mess up things. I've also had the experience of seeking care, as I said, and dealing with the trauma of being told that you can't get help. And it's too common of a story among us veterans. It's our responsibility to ensure that veterans have access to timely, high-quality health care. And in your testimony, you said that, like, you know, the men that I was able to help catch in the first, months really of trauma were the ones who were able to recuperate and put on a good path, and those that we weren't has been a very long, trial out. You mentioned the collaboration between Forge Health and VA showcased the potential of VA community partnerships, but also highlighted some of these ongoing challenges. Can you speak more specifically about what you saw in terms of inconsistent implementation, and what solutions you would recommend be implemented to address these issues in particular?
Yes, Senator. Thank you for your question. I think, again, going back to what I had mentioned previously, there are some VISNs and some VAMCs that are very collaborative and work well within the system. If there's delays, if there is and there are some where they were basically told not to refer out, no matter what the case was, right? So I think the standard, how we fix this, in my personal opinion, is to figure out a way to standardize those standards across the system to where, okay, every VISN, every VAMC has the same exact standards on how they are going to refer out, the number of people they're going to refer out. I understand that community care costs money, but there's, again, Senator, when you have a veteran and you don't catch them in time, and then they end up going to the emergency room.
It becomes more expensive.
It becomes way more expensive, right?
Yeah.
So how do we go upstream to prevent that? And so I think that standardized practice across the VISNs and across the VAMCs really is an important piece.
So some of that is like, tech, but some of it is just like SOPs, that as if we used to do in the military, no matter what unit you were, you did the SOP, so actually you didn't have to have massive retraining, and there was at least uniformity across.
And unfortunately, you saw it from the VAMC, where the providers or the people that were referring out would say, hey, I'm trying to refer, I understand this veteran needs that care, but the VISN is telling us no.
Got it. And Naomi, did I say that correctly? A great organization. I really appreciate Disabled American Veterans. They actually helped me get my my VA disability rating. So thank you so much. But wanted to follow up on that. Totally lost my train of thought. Are there currently any standards in place to ensure that community care providers are adequately trained to treat these types of conditions? In your opinion, also have you seen any specific instances where the lack of veteran-specific training standards have negatively impacted the quality of veteran care, at least from people that have been sharing with members, constituents of the DAV or other organizations?
Thank you for that question, Senator. Correct. There is a lack of training in community care. Currently, community care providers are only required to have opioid abuse treatment training, and this is as far as compared to direct care. So there's a difference between what the direct care providers are required to have and the community care providers. And so this is why we believe that if you strengthen the VA direct care, direct care, that then you would have better health outcomes.
And so community care, and I apologize, Chair, but so community care, sometimes there may be a veteran that goes but only ends up getting some treatment specifically for opioids, but not, for example, trauma, deep trauma, or anything else of that nature. So there's probably a mismatch at that point. And what you're saying is there's probably a better investment in direct care or potentially maybe also doing community care, hyping up community care, making them more accessible to traditional PTSD.
Where they would understand military culture.
Yeah.
Right, and so that's really where that opportunity is missed. Is you might have a veteran that presents before a community care provider, and they don't understand military culture, and they're missing the cues where this patient might actually be suicidal.
Excellent. All right.
Senator
Thank you,
Tuberville.
Mr. Chairman, yield back.
Thank you, Mr. Chairman. Ms. Marge, I apologize for what's happened to your husband. I had a couple of friends that went through the same situation. Terrible outcome. Even some were arrested at the VA for not having a appointment and run off of property. It's a terrible mess. How do you communicate with other service members or family that come to you and ask you about your husband's problem? I mean, what's that conversation like?
I will tell them that any story that they've heard about the VA is true.
Yeah.
When I've heard other people's stories, when I first heard them, I was surprised and shocked that, like, this must be a one-off situation. But my husband has been medically retired since 2015, and it seems like every step along the way, it is just such a struggle. And there's been many times where my husband has just felt that he's done, and I tell him he's not, and we just keep fighting. And sometimes it takes going to an outside entity to get help, which I'm incredibly thankful that it exists, but that's ridiculous.
Ms. Mathis, I heard you say something in your opening statement. Are we still having problems getting information from the DOD to the VA?
Yes, sir. There is no interoperable.
And we spent billions of dollars doing that. Billions, not millions, but billions. I wonder why we need a new IG. Yeah. I wonder why we need to freeze the funds. We find out what the hell's going on. It's embarrassing, absolutely embarrassing. I mean, the biggest healthcare system in the world and second largest budget in our country, and we can't figure out how to get information from one entity to another. But you know what? I've talked to people that said they could do it, but we won't go to those people. For some reason, we keep going to the same people. Any follow-up?
Senator, I think that's something that VA needs to really get a handle on, which is the records issue and the electronic health record system. I believe, and I probably misspoke, I believe that VA, DOD are probably easier to speak to each other. But when you talk about community care and VA is where you have the rub, is where you have the issue. Records are not coming back into VA from community care, and they're not going out, say for a mammogram. If I go for a mammogram for 3 years in a row, I go to the same provider, right? And then VA sends me, I don't know, maybe to another provider. That provider that is going to look at that radiograph needs to see the previous other images, not just the report. And so then the onus is on the veteran to transfer those records and those images from one provider to the next or from the provider to VA. And so, that's where they really need to have an interoperable system, a system that talks to each
We
other.
have the same problem in the DAV, just as bad as we do in the VA of information coming back and forth that was the disabled veterans.
In DAV?
Yeah. The same problem, information-wise, the exchanging of the information from one entity to another.
You mean from VA?
Yeah.
Oh, from VA to DOD, they've actually worked on that with Cerner, with Oracle. But it's really the issue is from community to entity.
Thank you, Mr. Chairman.
Thank you, Mr. Chairman, and I want to welcome our witnesses for being here. Family members, our caregivers, and thank you, Ms. Mark, for your standing by your husband. As far as DAV, you hold my power of attorney as well, and says something. And Mr. Eaton, Mr. Eaton, there might be a conflict of interest. They both of our, and Mr. Eaton, I think I was the first female patient to receive a care pack, one of the backpacks that Wounded Warrior Project handed out at Walter Reed. I think I was one of the first 10 you ever handed out. Unfortunately, it had jockey shorts, socks, and a shaving kit. None of which I could use, but my husband thanks you for them. The kits are much better now because they now, with the presence of women, they took my advice and readjusted. So, but certainly Wounded Warrior Project was there for me very early on. I do want to take a moment to bring attention to the outrageous EO that President Donald Trump signed last night, and my colleague, Senator Blumenthal, touched on briefly that this EO paused all federal grants effective 5 p.m. Eastern Standard Time today. We are in a hearing room full of policymakers and citizens dedicated to the welfare of our nation's veterans. But let me tell you what this means for you or your loved ones who receive care from VA. This EO will pause critical and life-changing VA grants, including those that aid in VA's mission, ranging from community-based suicide prevention efforts to rural veterans telehealth access and transportation services, to hiring and retention of nurses at state veterans' homes, to specially adapted housing, assistive technology, and so much more. It is sadly ironic that we are here today to discuss expanding access to care for veterans. Meanwhile, the Trump administration is actively preparing to restrict their access to care in just a few hours' time. What happens then, in the meantime, to veterans who rely on these grants for suicide prevention resources? What happens to rural veterans who rely on VA transportation services to travel to their VA medical center? What happens to veterans who rely on these grants to live independently? This EO, which is illegal, by the way, creates chaos and threatens the stability of these programs that, in many cases, offer lifelines to people who sacrifice for their country. Congress alone has the power of the purse, and Trump unilaterally freezing billions of dollars of federal grants and loans that Congress already approved is unconstitutional and will hurt millions of people across this country. I hope that my Republican colleagues and the courts have the spine to stand up to Trump in the face of this cruel, chaotic, and unconstitutional order that hurts everyday Americans, including veterans. I could not agree more with the frustrations that have been described with trying to access care through VA, within VA itself, as well as through community care. I have both. I get care in the community because the VA cannot provide me care, for example, with the extremely advanced prosthetic devices that I use. I should have the right, and I do have the right, to choose the prosthetist who provides me with that care. It's very ironic because the VA provides care for my left leg, but my prosthetist in the community provides care for my right leg. So it's really important to me that they talk to each other because otherwise it makes it very difficult to walk. And Ms. Mathis, I think you're touching on this communication piece is critically important. When I went from DOD to VA, I was given a CD-ROM. I had to wait 90 days to go talk to VA, at which point I went and saw a physician assistant whose job it was to determine whether or not I was still an amputee. It was a waste of his time. It was a waste of my time. He wanted to be taking care of veterans, and yet he had to go through this rigmarole. To this day, there is still lack of good transferring of information from the DOD to the VA. It is also compounded when you go to community care. I do think that we need to do much more to allow veterans to make their own decisions. And Mr. Golnick, I appreciate that you brought attention to this very issue in your witness testimony about veterans being able to make the decisions. In your opinion, how should VA be ensuring that veterans are getting the information they need to make appropriate decisions about their care, including the choice to receive direct care at VA? Because VA needs to be your medical center home. I think you should go to VA. That's your medical center home. They look at you and they're like, okay, you're an Iraq veteran. we're going to take care of your mental health, but also you may have respiratory illnesses. You need to be informed, and then if you want to go to community to get the care, that should be made seamless. Can you speak to that?
Yes, Senator. I do think it's an education thing, and I think on the ground level, and I'm sure both of you have seen this before, where the clinicians at the ground level at VA, they want to do the right thing. They want to get veterans into care immediately. They want to get the care that they need. I think where it gets gunked up is when it gets up to a different level, right? So it starts going up to the visit level, they're putting the referral in, but in terms of educating, I think there needs to be an education across the VA system of, hey, these are your options. These are the things that are out there. Here's what we can provide, here's what we can't provide, or it's gonna take too long, and here's how you get there, and this is the process to do it, right? So I think there really needs to be an education on the ground level, and I think it needs to go all the way up to the visit level.
Thank you. Thank you, Mr. Chairman.
Senator Duckworth, Senator Blackburn. Let me indicate there's a vote at noon, and we have less flexibility than we used to have in rolling the time frame. So I'm going to try to keep everybody to their 5 minutes. Senator Blackburn.
Thank you, Mr. Chairman. I appreciate what Senator Tuberville said, and Senator Duckworth just alluded to this, that it is very difficult for the veteran to get their records. And I think one of the things we should look at is who owns those records. It would be so much more helpful if the veteran himself controlled those records. If individually we owned our healthcare records, every one of us. And then that way you wouldn't have the problem that you're talking about, Ms. Mathis. The veteran would be in charge of their records and would be able to take it, whether they're in community care, whether they're in TRICARE, because we have seen just an inordinate amount of waste in trying to build the electronic health records, whether it is Cerner, Epic, Oracle. It is like they can't figure this out. In Nashville, Tennessee, we've got a lot of health IT innovators. They can figure this out. And one way to do it is to let individuals, not the doctor, not the insurance company, not an agency, own their health care records. I also want to say I find it very sad that for many of our vets, Tunnel to Towers and Wounded Warrior are the people that can help them get help, because the VA can't figure out how to do their job. They're still working remote. They do not show up. It takes forever. That's why there are 956,000 claims in the queue and nearly 300,000 over 120 days, and veterans cannot get a response from these people. I know a lot of it is because of the union that is there at the VA that is stifling access to this care and benefits. And I find it just something that should not be tolerated, and it's frustrating to the veterans that we're trying to serve. And it's why community care is so vitally important. And Ms. Marge, thank you for speaking to that. Mr. Golnick, I want to come to you and thank you for your service. And thank you for what you're doing with Forge and trying to solve a problem, because the VA has thrown up barriers to health care. And you're trying to get around that and improve access. So I want you to give like a 1, 2, 3 point. What could this committee require the VA to do to improve that access?
Thank you, Senator. And just to be clear, I am a co-founder of Forge. I've stepped down from full-time with them, so I'm representing myself. But
Yes.
but I will say there are things, and to your point, Senator, I think there's a lot of friction points that are preventing veterans from getting access to care, especially when you're talking about mental health, right? I think what this committee could do is work with the VA to ensure that they're educating veterans, that the VA is educating veterans on what their options are. Number 2 would be the administrative side of this, ensure that the access standards are codified so people that within VA system know, okay, if X then why, right? I think that's as simple as that. And then I think ensuring that there's some oversight on certain VAs and certain VISNs in terms of that care making sure that care, the veteran is the true North Star. It's not what their local budget is. It's not anything else. Care of veterans should be the true North Star of all care decisions.
I agree with that, and putting the veteran at the center, that's why I've got this VA Healthcare Freedom Act that would remove those obstacles and really put the criteria in the Mission Act for eligibility for community care and give full choice to veterans in select regions. Let's roll this out as a pilot project and then put it on a 4-year path to fully implement it so a veteran can go get what they need, when they need it, where they need it, show their VA card, and the VA gets the bill, not the veteran. And that would solve this and this enormous backlog that we have. Give the veteran the choice. Put them at the center of this. Thank you, Mr. Chairman.
Senator Blackburn, thank you. Senator King.
Thank you, Mr. Chairman. In answer to Senator Chobelville's questions, I think the beginning of this electronic medical records problem started with a no-bid contract about 5 years ago, 6 years ago, that was extended by the last administration. And I still don't understand why we don't go out to the market where I'm sorry you mentioned Epic, Senator, because Epic is a successful medical record system that I've observed in my system. Well, okay. In any case, it seems to me in order to analyze the issue of the relationship between VA direct care and community care, we need more data. We know exactly the VA wait times and all those kinds of things. We don't have that kind of data in terms of the private sector. I know in the private sector in Maine, it's pretty hard to get an appointment, and whether particularly with a specialist. So I think in order to make policy here, Mr. Chairman, we need some information. We need to have cost comparisons. We need to have time comparisons, wait times. Everybody's nodding, but that won't show up in the record. Could somebody say yes, yes, Senator,
Yes,
you're
Senator.
right?
Yes, Senator. I wholeheartedly agree. There is no data coming back out of the community back into VA, and there is no sort of accountability either when the records don't show up back to VA. So you have a provider, a primary care provider, say at VA, that may have sent a patient out to the community for specialized care, and the information, when the patient comes back to VA, the information is not coming back. Therefore, that provider is not able to provide an accurate treatment plan for that patient.
So we know, we don't have a handle on cost, quality, or time. Is that correct?
Correct, Senator.
And by the way, when we're talking about the time of VA's responsibility and backlogs, a staff freeze isn't going to help that problem. If there are fewer people to answer the phone, fewer people to process claims, that's only going to exacerbate the problem, not make it any better. And I note that the administration the other day appeared to walk back part of the hiring freeze with regard to direct care providers, but to leave a hiring freeze in effect that has fewer people responding, processing claims, and those kinds of things, that's in effect a denial of benefits itself. Is it not, Mr. Eaton?
Yes, I think the big focus area, and that's where we come in, and Senator Duckworth mentioned in terms of the backpack, we received our start, in 2003, providing backpacks to the first injured, ill, and wounded warriors coming back from Iraq and Afghanistan, and we made a promise. And so we'll continue that promise that we'll be there for their needs for a lifetime. And so we're doing that today in times where there's changes throughout the system, that we can be a constant to support them and remove barriers to increasing access to care.
And I think one other factor we need to talk about when we're talking about private sector is that there are huge shortages in the private sector. My major hospital, one of my major hospitals in Maine, is down something like 800 nurses. And so to say it's not enough to say, oh, the community can take care of it, when indeed there are shortages in the community in terms of CNAs, nurses, psychiatrists, psychologists, and I think we need to recognize that there's no simple answer to this. To me, the answer is better coordination, better data, and understanding the results that we want for our veterans. That's really the goal. Is that correct?
Yes, Senator, absolutely. And to your point, even the private sector, a lot of the commercial payers aren't even collecting this data because it makes them look bad if the wait times are too long or any of this other stuff. So it really needs to be complementary.
I just want to be sure we're comparing apples to apples when we're deciding policy here, and that we don't move toward a policy that in the real world doesn't necessarily improve things for the veterans. And I'm just concerned that we not hollow out the VA capacity and then say, oh, look, the VA's not doing very well, when we've made it impossible for them to do the work that they've been charged to do. So I appreciate you all joining us here today, and look forward to continuing to work with you, because I think this is an issue that needs attention. Thank you. Thank you, Mr. Chairman.
Senator, thank you. The Elizabeth Dole Act that we passed and became law requires significant data collection regarding community care. So maybe we'll have some information that we can make that analysis. I also point out that I've argued with the VA about when the wait time starts, and they want to start the wait time when the appointment is made, not when the veterans ask for the appointment. I don't need to
It
get
ought
into
to start
debate.
with the call.
Yes.
Thank you.
Senator Kramer.
Thank you, Chairman. Thank you to all of you for being here and for your testimony and for your service. So a couple of things come to mind. Well, one of the things with regard to Senator King's comments about shortage of workforce, that's a real problem. That's a problem in healthcare. It's a problem in manufacturing. It's a problem in everything. But it is particularly challenging in healthcare, which is why the CMS rule, the staffing rule, is so awful, because it literally provides less opportunity, because it runs the risk of shutting down healthcare providers simply because they don't have a 24-hour-a-day, 7-day-a-week RN. And I would submit to you that access is not just about the quality of the care, it's about access, period, if the alternative is none. And so while standards are important, I would also submit, I don't share some of my friends' view that it shouldn't be competitive. I think the best way to improve care is competition. Whether it's a competition against a competition between the private sector and the public sector, or two private sectors or two public sector agencies. A little bit of competition is fine. I agree. I don't want to gut the VA's direct care system. There are unique things about the VA that I know several of my veterans. I have a veteran who would drive 300 miles to Fargo every day before he would see a local provider, particularly for counseling. All of that said, there are all kinds of barriers to community care. A lot of it is the bureaucracy itself. I mean, even in North Dakota, where we have quite a cooperative VA hospital in Fargo, we hear many stories of roadblocks being put up to community care. They check all the boxes except one, or they only check 99 out of the 100 boxes. Therefore, no. I just think we need to make it. I agree with what Senator Blackburn said. If we put the choice in the hands of the veteran, the market will determine where they go. The type of care they get will determine where they go. How long the wait is will determine where they go. So, a little bit about North Dakota. We have one VA center. It's in Fargo. That's the right on the Red River. I mean, literally right. It's on the shores of the Red River, which is the barrier, the border to Minnesota. That means if you're in Williston or Dickinson or Beach or you might be 400 miles away from the VA hospital. We have 8 CBOCs, I think it is, and we have 37 critical access hospitals. Critical access care hospitals are there on purpose, and it has to do with access, right? And they're reimbursed by CMS in a particular formula. And we have veterans. And by the way, I think it's just a handful of those CBOCs are in the same community as critical access hospital. What I'd like to see us do, and I've got a proposal to do this, and you'll be hearing more about it eventually, but, and if training's required, I'm all for it. But for many of these critical access hospitals, their margins are this thin. They're barely hanging in there. And 2 or 3 more patients or 5 more patients in the community might be what keeps that hospital open. And if it's 50 miles to the next hospital or 350 miles to the VA hospital, that critical access hospital might be the only provider that could save a veteran. I'd like to make this automatic. We can, no doubt, smart people can figure out the records thing. I don't know why it's taken so long if they can. I would, and maybe I'll start with you, Mr. Lorraine. Is that plausible? Is there am I somewhere in the ballpark of a possible solution in a very, very rural place?
Yes, sir. I've been to Minot. I know how rural and out there it is.
That's one of our biggest cities.
But, one of the things that I spoke about was continuity of care. Yeah. And not only continuity of care, as a healthcare provider, I want the family there. I want the physical therapist nearby. I want the staff that does this. And we talk a lot about mental health and substance abuse, but it's really more than that. We're talking about access to healthcare. Right. So it's surgery. How many total knees are done in this location versus this location? So the answer is, we need to look at what's the best long-term outcome for a veteran in terms of getting their care. It may be the VA that's in their community, but it may be your local hospital that the family can be present, the physical therapist is there, the staff is invested, and it's all one. Thank you. Sorry.
I'd just rather have it easy rather than confusing and then likely a denial for community care. Thank you.
Senator Hassan, thank you, Chair.
Well, thank you, Chairman and Ranking Member Blumenthal, and thanks to all of our witnesses for being here today. Whether you've served, been an advocate for veterans, or both, we really appreciate your support for and commitment to our veterans and to our nation. I appreciate that this hearing is focused on community care. It's a really important component of providing care to our veterans, especially in a state like New Hampshire, which doesn't have a full-service VA hospital of its own. It matters that we get this right and that we ensure that veterans who qualify community care really get prompt access to it, understanding, as Senator King has pointed out, that access in the private community care system is challenging for private citizens as well right now. But before I get to any questions, I want to take a moment to discuss what are illegal and unconstitutional acts by this administration because of the way they affect the very issues we are talking about today. As Senator Duckworth referenced, the administration last night ordered a full halt on a whole lot of federal funds, including some states are now locked out of Medicaid funds. Community care in rural areas that Senator Kramer was just talking about won't exist if rural hospitals don't exist, and they are very dependent on Medicaid. But the administration appears to be halting that funding, as it is halting critical funding today for veterans in rural areas that depend on it. The administration also took an illegal act when it decided to unilaterally try to fire inspector generals contrary to law. And this is really troubling for a lot of reasons, but just for example, the VA Inspector General's office just released a report last fall on community care scheduling delays in the VA health service. But the administration has unilaterally, contrary to law, decided to fire all of these inspector generals. The report that inspector general did concluded that leaders had failed to focus on the patient, respond to staff concerns, and get to the root cause of concerns regarding delayed scheduling of urgent consults. This type of work, holding government accountable and making sure that our system operates as efficiently as it can, is at the heart of what independent Senate-confirmed inspectors general do. So that's why I am really concerned by President Trump's illegal firing of at least 17 inspectors general over the weekend, including VA Inspector General Michael Misal, who was confirmed to that position with unanimous consent by the United States Senate. The letter to these inspectors general said that priorities were changing. That's what the Donald Trump administration said. What greater priority is there to ensure that taxpayer dollars are used well? Well, it is in the interest of every American that these public servants be able to investigate waste, fraud, and abuse without political interference and be able to stand up to powerful interests without fear of losing their jobs. We owe that to our country and especially to our veterans. Now, I have time for a couple of questions. I want to start, Mr. Eaton, with you. In your written testimony, you discussed some of the obstacles veterans encounter when seeking mental health care, and in particular, identified that more providers are needed regardless of whether they are in the community or in the VA system. Mr. Eaton, can you please speak to the need for veterans to have access to steady, high-quality mental health treatment and how increasing the number of mental health providers could support that?
Thank you for the question, Senator. When you think about an effective care team, and we understand, first of all, the personal journey that it takes to get to that first appointment. Building a relationship, rapport, and telling your story is incredibly meaningful to building that relationship. But so as VA employees or even Community Care Network employees are transitioning, really it leaves the veteran to navigate that system again on their own. And so as we've highlighted here today, not only a veteran issue, but also just as civilians in general, mental health is a shortage area. And so looking at ways to incentivize providers, create environments where practicing medicine and mental health is a thriving environment is really important as we're helping to build up a system to support veterans.
Well, I appreciate that. Thank you very much. Ms. Mathis, community care provides a chance to receive timely, quality care close to home for many veterans who don't live near VA facilities. This is especially true for rural veterans and veterans who live in states like New Hampshire that don't have a full-service VA hospital. Ms. Mathis, could you please discuss the importance of ensuring timely access to local care for rural veterans and the role that community care plays in ensuring that veterans get the care that they need and deserve?
Absolutely. Thank you for that question, Senator. As outlined in the Mission Act, it should be complementary, the two. We're not, we believe that access to community care is essential, especially in a rural community where, you're fighting with the community to get specialized care. And so, yes, absolutely. Access is critically important and really could be life-saving.
Thank you very much. Thank you, Mr. Chair.
Thank you, Mr. Chairman. Mr. Golnick, healthcare organizations get more frustrating and impersonal the bigger they get. I think we all agree about that. And the Veterans Health Administration is the largest hospital system in the country. Why do you think the VA is so bureaucratic, and what can Congress do to change that culture?
Senator, that's a tough question. Every large healthcare system is frustrating, right? There are a lot of things that are structurally in place that I think are important things that are safety, especially when you're talking about mental health, right? Like accreditations, certain things, clinicians should have a certain criteria. I do think, again, I don't think it's on the clinical side that we're seeing the issues. Where I see the issues are when you get up into the administrative, right? I think the processes that are in place right now between VA into community care and back and forth, what my colleague from DAV has been talking about, that's really where I think there could be some good work done in codifying those access standards so that everybody in this bureaucracy, I look at things from as a naval officer, right? They always said the instructions are written in blood, right? Because there needs to be a very clear line that shows, okay, if X, then Y. And we don't see that a lot in a lot of these places because there's no standardization.
Yeah, as a Navy officer, you understand culture, though. So how do we change the culture? And what can I do, members of the Congress, do to force that culture to change?
I think the ability to ensure that the leadership at VA, I've talked to some VAMC directors in my time where they said, I give directives, not orders, right? So sometimes things are not just followed, right? So I think there needs to be, in order to change that culture, I think really streamlining and codifying things in a more clear manner and having an SOP and having those things in place is going to ensure that people are following the letter of those instructions, right?
Well put. Mr. Lorraine, we hear a lot about community care being too expensive. It accounts for about 40% of veterans' health care, and it makes up about 25% of the VHA budget. That sounds like a pretty good deal to me, isn't it?
Yeah, it is, but I don't think we've given enough chance to the community care to measure the long-term impact of local, meaningful, well-rounded healthcare. The other thing, if I can just add to the question that you asked, Eric, in my opinion, the veteran needs to be the center of the universe for the VA, not the VA the center of the universe for the veteran.
Amen. Well put. The VA added 120,000 employees over the last decade, and I support giving the VA the resources it needs to take care of our veterans, but there are only so many doctors and nurses to hire. How do you think the department can deliver more health care with the personnel that it already has?
I think there needs to be not managed health care, but coordinated care. Coordinated care, somebody needs to take responsibility for the veteran and connect them to private organizations like WWP, public healthcare providers that are in the community care network, and the VA to look for the best opportunity, but to unify, to coordinate the care for the best outcome. It doesn't just need to be in the VA.
Mr. Eaton, we want VHA care and community care to complement each other, not compete as they have over the last decade. What VA policies need to change to make that happen?
Thank you for the question, sir. I would say, again, we've hit on throughout today standard access across the board. We think about VHA as the largest integrated health network. That's their direct care, but also the community care network. And these are cultivated networks created in partnership with third-party administrators that have been found to offer high-quality, veteran-centric care. And so having the same standards and then care coordinated throughout the entire system, not thought about as two separate, would be really a great first step.
The VA has 120 residential mental health rehab facilities, and veterans in crisis are waiting about 3 weeks to get placed. It takes the VA 3 to 5 years to lease a new facility. Do you think the VA could ever open enough residential rehab facilities to fully meet the veterans' needs?
I think if we take a step back, that's why the community care network exists, right? To really complement the VA in areas where there's gaps, higher demand, and where veterans' needs are most sought. And so I think if we take a step back and look at all inputs from both footprint from the VA as well as the community care network, we'll have all the data points to make an informed decision.
Thank you. I yield back.
Senator Banks, thanks. We're not doing another round because if somebody else walks in the door, I'm in trouble on the time. But Senator Blumenthal has a couple of questions, and I have a couple of questions, and we're going to wrap this up. A vote was expected at noon. We no longer have the flexibility because we're attempting to enforce the votes only lasting 15 minutes, and we used to be able to do this much differently, but we cannot. So, Senator Blumenthal.
Thanks, Mr. Chairman. I have a few questions which I think are answerable by yes or no, because what I'm hearing is, as Mr. Lorraine said so well, veteran ought to be the center of the universe. Veterans' choices should be respected. Veterans' decisions should be informed so that the veteran's medical interest is put first. And an informed decision can't be made by a veteran based on an ad that she sees on television saying, go get this drug. You know, anybody watching TV these days, you are deluged by ads that depict certain drugs as cure-alls. A veteran shouldn't be permitted to go into the community and just say, give me this opioid. I assume all of you would agree.
I would agree with that, Senator.
And I'm taking the absence of a disagreement as a yes. Let me pose another question to you real quickly. My fear, as I said at the very beginning, is that there will be an erosion, a starving of the VA because the attempt to shift care to the community without veterans having choices will mean less investment in the VA system. In Connecticut, we're rebuilding our VA facility in West Haven. It will provide for a new surgical suite, new parking, new care facilities, particularly for women. That kind of investment will make VA care better than it is now. I assume all of you would agree that we need to make those capital investments in VA facilities across the country and maybe build facilities in parts of Kansas that right now don't have any. Would you all agree?
I disagree, sir.
I'm sorry?
I disagree.
Tell me
I
why.
don't think that we can build enough VA facilities to meet the needs of every veteran in the United States. I think that there needs to be a merge between good VA facilities and none. I don't mean to use up your time.
And you are absolutely right. And if I was unclear, I'm not saying that VA facilities should be built for every veteran. We need some community care, no question about it. But the VA facilities that exist right now, serving veterans in Connecticut or Kansas, should be the gold standard. They ought to be top flight. They ought to give veterans the best care possible. Would you agree with that point?
100%.
Thank you. Let me just conclude by saying, you know, this conversation seems a little bit surreal this morning because I'm getting emails from healthcare groups in Connecticut whose funds have been frozen. These are suicide prevention, their addiction treatment, their payrolls are halted, their budgets are in danger. We're talking here about community care potentially decimated. There's chaos and confusion as a result of this freezing of funds. You know, in my prior life as Attorney General in the state of Connecticut, I would be in court saying that this action is illegal, it's unconstitutional. Congress has the power of the purse. It's a seizure of that power, monarchical and autocratic, and it's a violation of the Impoundment Control Act. But put aside the legalities, it is potentially devastating to health care for veterans. The Fox suicide prevention program that was mentioned is just one of literally tens, maybe hundreds of programs that are in peril right now. And so I call on my colleagues to join in protesting and opposing. Once again, I ask veterans to rise up and say, please, Mr. President, clarify that you're not going to make veterans the victims of this illegal policy. And the same point I would make as to the firing of inspectors general. Accountability for community care as well as veterans care. Let's put veterans care first and foremost, including holding accountable the VA. The VA ought to have its feet to the fire, as Michael Missel has done as Inspector General. He's saved $40 billion. That's a rough estimate. And there was a mention of the electronics record program. There was a provision in the Dole Act that would have provided more accountability for the electronic records program. Apparently, it was deleted at the last moment. I think we can include it in whatever legislation we pass. I'm fully in favor of making sure that standards and criteria are applied and that they eliminate wait times, whether at the VA or in community care. Mr. Chairman, I really appreciate your leadership. I know you made reference to the importance of inspectors general when we had a hearing recently. I think this cause can be bipartisan and that the hiring freeze, as Mr. Eaton said so well, can be clarified so that it doesn't affect the VA and our veterans' care. Thank you, Mr. Chairman.
Thank you, Ranking Member. Thank you, Ranking Member. There are 5 minutes left in the vote, but I still have questions. So we're about done. Mr. Eaton and Mr. Lorraine, both the Wounded Warrior Project and American Warrior Partnership indicate they've seen trends over the last year indicating pressures from VA administrators on VA providers to not place referrals. For care in the community, would one or both of you explain what you've seen?
Yes, sir. Thank you for the question. What we're hearing from clinicians is really that pressure from an administrator perspective to minimize referrals out and even a referral decision being made at the administrative level versus a clinical level. And so this could mean that instead of going out into the community, a longer wait time for care within the VA, it could also result in a different level of care than initially indicated. So whether individual counseling could be shifted into a group setting, which is really not aligned with what the veteran was looking for or what his clinician recommended, his or her.
And that, I mean, just for me to point out what I think is obvious, that can very well be contrary to what's in the best interest of the veteran patient. And who but the VA, including their administrators, ought to be the most interested in the quality and not only the timeliness, but the quality of the care a veteran receives. I spoke about this, and it bothers me because for my involvement in veterans issues for as long as I've been in Congress, I sometimes can get individual cases altered, fix a problem for a veteran, but it doesn't seem like when I do that, it fixes the problem for the system, for every other veteran who's experiencing the same thing. I highlighted on the Senate floor the veteran in my hometown who was receiving cancer treatment, 60 treatments. He was receiving them in the community at the authorization of the VA. He'd had 59 treatments of the 60 he needed, and the VA called him back to the VA hospital for the 60th care treatment. The other example is the constant, I mean, I've indicated so many times that what I think I know is based upon what I hear from veterans. What we call casework is part of that. The number of times, for example, that chiropractic care has been recalled back out of the community. So you have a veteran who's been receiving chiropractic care with the same chiropractor for months and years. But the VA says, no, that's no longer permissible. Community care will not cover your visit to a chiropractor. Come back to the VA. Those decisions can't be being made based upon what's in the best interest of the health care and well-being of the veteran. So we need to get the VA needs to, I mean, I was involved in the creation of the Mission Act. One of the components by which a person can be referred to community care is what's in the best interest of the veteran. And we intentionally defined best interest of the veteran to be determined by the veteran and his or her provider, not an administrator at the VA, so that the decision is made on the best health care interest of the veteran, not on the financial well-being or the caseload of the VA. And it just, I mean, I'm all interested in seeing that the law is complied with. And that's what I have spent so much time in trying to convince in recent months the VA to utilize the Mission Act in the way that it was not only intended, but in many instances actually written. So we're trying to get the law to be the law at the VA. And I appreciate the testimony that we heard today, and I think there's a takeaway for me, and I hope others, that this is particularly important, Mr. Golnick and Ms. Marge, when it comes to mental health, suicide ideation. All the care for veteran matters, but there are certain things in which the timeliness and the consistency and the personal nature of the care determines the outcome and whether there's success. And so I take your testimony very seriously with a renewed interest in trying to be a better advocate for not just community care or the Mission Act, but community care and the Mission Act as it may save a life and improve the quality of life of veterans who can't get what they need within the VA. I wanted to talk about residential treatment and the length of time, but I don't have the time, but that has captured my attention as well. What can the Department of Veterans do to provide more longer-term care for veterans? I'm going to conclude the hearing. It's concluded with this expression of gratitude for all of your presentations and your willingness to visit with us. And we'll try to be a committee that listens to those who tell us what the challenges are and respond appropriately. Each member of our committee has 5 legislative days in which to revise and extend their remarks, what we all said. And I ask any senator who'd like to submit a question to you to do so in a timely manner, and we'd like for you to respond for the record following today's hearing in a timely manner as well. With that, this hearing is adjourned.